tibula and fibula. So the tibia is the large weight-bearing medial bone. So this is the tibia, and the fibula is the slender lateral bone. So this is the fibula. So there are 3 surfaces and 3 borders for both tibia and fibula. So medial surface, posterior surface, and also lateral surface of the tibia. So the between the medial surface and also the lateral surface, it has the anterior border. Between the medial surface and also the posterior surface, it has the posterior border. Between the posterior surface and also the lateral surface, it has the interosseous border. So for the fibula, it has posterior surface, lateral surface, and also anterior surface. Between the anterior surface and lateral surface, it has the anterior border. Between the lateral surface and the posterior surface, it has the posterior border. Between the posterior surface and the anterior surface, it has the medial crest. So, and there is a membrane between the 2 tibia and fibula, which is known as interosseous membrane. So next, and let's look at the upper end of the tibia. Anteriorly, it has the lateral side, it has the lateral condyle, and the medial side, it has the medial condyle. It has tubercles of intercondylar eminences, and at the upper end, it has the anterior attachment of the medial meniscus. There is a prominence in the tibia known as tibial tuberosity. We can also feel it whenever we touch. So this is the site for the attachment of sartorius, gracilis, and semitendinosus muscles. So as going down, this is the shaft of the tibia, and posteriorly it has the soleal line, and it has the attachment of medial meniscus and also for the posterior cruciate ligament. So the interosseous membrane is actually attaching the tibula and fibula together. So this is the anterior, looking at the anterior, from the anterior view, this is the anterior tibio-fibular ligament that connecting tibia to the ligament that connecting tibia to the fibula. And in between, there is an aperture in between the interosseous membrane for the flow of the anterior tibial vessels. So when we look at the posterior, down there we have posteriorly we have the posterior ligament that connecting the tibia to the fibula, known as posterior fibular ligament. And there is aperture also at the lower end of the tibulofibular in between for the perforating branch of fibular artery. So let's look at the contents of each compartment of the leg. So this is the tibula, this is the fibula. So in between the membrane, interosseous membrane, so anteriorly we have the anterior intermuscular septum, and posteriorly we have the posterior intermuscular septum, and there we have transverse intermuscular septum. So this is the anterior compartment has extensor muscles, tibialis anterior, extensor digitorum longus, extensor hallucis longa, fibularis tertorius, anterior tibialar artery and vein, deep fibular nerve. And laterally we have lateral compartment. The lateral compartment has fibularis longus muscle, fibularis brevis muscle, superficial fibular nerve. And the posterior compartment, it has 2. First is superficial posterior compartment and deep posterior compartment. So the superficial and posterior compartment has superficial flexor muscles, soleus, gastrocnemius, and also plantaris with tendon. So the deep posterior compartment has deep flexor muscles, flexor digitorum longus, tibialis posterior, flexor hallucis longus, popliteus, posterior tibial arteries and vein, tibial nerve, fibular artery and vein. The tibial artery has actually two branch, anterior tibial artery and posterior tibial artery. So this tibial artery is originates from popliteal artery, which originates from the femoral, that a branch of this sciatic nerve. So the anterior tibial artery passes through the aperture in the upper part of the interosseous membrane and enters the anterior compartment of the leg. So just now we saw the an aperture over here, right? I mean at the upper end of the interosseous membrane, right? So it enters through there and then going to the anterior compartment, and the posterior tibial artery descends posteriorly along the posterior compartment under the flexor retinaculum of the ankle, and it divides into the medial and lateral plantar arteries. So any clinical anatomical problem is classified according to the Schaefer classifications. So there are 6 types of Schaefer classification. Type 1, so the type 1 is lateral plantar split fracture. Type 2, lateral plantar split depression fracture. Type 3, lateral plantar central depression fracture. Type 4, medial plantar fracture. Type 5, bicondylar split fracture. Type 6, plantar and proximal shaft fracture. So first is type 1. So type 1 is actually lateral split fracture. So this is the lateral, there is a vertical split over the lateral condyle. So wedge shaped pure cleavage of the lateral tibial plantar with a displacement or depression of more than not more than 5 mm. It should be less than 5 mm, then only we can classify it as type 1. So it is usually caused by lateral femoral condyle being driven into the articular surface of the tibial plantar, and is common among the young people. So this is the image of x-ray of the lateral tibial plantar fracture over here. I hope you can appreciate the picture. So second is type 2, lateral split and depressed fracture, which means there is a split and also depression of the lateral tibial plantar, and the depression is more than 4 mm, and it is associated with the lateral meniscus tear. So this is the split of the lateral tibia and also the depression of the lateral tibial plantar. Third is type 3, lateral pure depression fracture. So there is no split of the lateral condyle in type 3. There's only complete depression of the fracture of the lateral tibial plantar. And the articular surface of the tibial plantar is depressed and driven into the lateral tibial metaphysis by axial forces. The split to the edge is absent. So this is the left side, which means this is the lateral part. So as you can see, there is no split of the lateral condyle. However, we can appreciate that there is a depression of the lateral tibial plantar. Fourth, type 4, the medial plantar fracture. So in the medial plantar fracture, the medial condyle is split or depressed. It may be there may be a vertical fracture of the medial condyle, or there can be also depression of the medial condyle. It's combined forces of the axial loading and hyperflex knee. That is the worst prognosis, as you all can appreciate. So this is the lateral condyle, which is attached laterally to the fibula, and this is the medial condyle. There is a vertical edge and also depression of the medial condyle. Type 5, bicondylar fracture. So from the name, bicondylar means that we have the two condyle, the lateral condyle and the medial condyle both has a vertical fracture. So thus it gives a wide appearance when we do the x-ray. The articular depression may be seen in the lateral plantar. The last one is type 6, metaphyseal diphyseal disassociation. So the metaphyses dislocate from the diphyses. Combined condylar and subcondylar fracture. There is a condylar and also subcondylar fracture due to the high energy trauma. As you can see, the metaphyses is separated from the diphyses here, and there is a even the condyle over here is also fractured. And treatment, the treatment is according to the what type of fracture is that. For the type 1, if there is no displacement of the fracture, we can treat it conservatively. If there is a displacement of the fracture, it should be treated by open reduction or internal fixation. So for type 2, there are two options: closed reduction and also open reduction with elevation of plateau and internal fixation. So for the closed reduction, it is done when the knee is unstable or the patient is osteoporotic or the depression is more or less than 5 mm, which means it between 4 to 5 mm, and the aim is to regain the mobility. And for the second one, it is in young patient with a central depression of more than 5 mm. So for the type 3 and type 4, it has the similar treatment. Principle of management of type 2 fractures: the depressed fragments may need to be elevated through a window in the metaphyses, and reduction should be checked on X-ray or arthroscopy, and the elevated fragments are supported with bone grafts, and the whole segment is fixed in position with graft screws. So post-operatively, the patient should begin to do exercise as soon as possible. For type 5 and 6, so with the management of for the type 5 and 6, it carries a risk of compartment syndrome. So the management is actually surgical repair or temporary external fixation followed by surgical repair. It is to provide provisional stability. If both sides need to be fixed, the medial and lateral plate fixation should be done through the double incision approach, usually in anterior or posterior medial incision. So the complication of the surgery, the earliest complication is compartment syndrome, and the late is joint deformity, stiffness, and osteoarthritis. So what is compartment syndrome will be explained later.